Invite Dr. Alok Samantaray from SVIMS Andhra Pradesh. Sir is a professor and head of Department Anesthesiology and Critical Care in SVIMS, and he is the training center coordinator in American Heart Association Training Center in SVIMS. Sir has 51 indexed publications. He received Dr. Kopp's Award for Trauma and Critical Care at SZISACON 2006 conducted at Mysore. And he received Best Reviewer Award from IJA 2016, and he received Andhra Pradesh State Best Teacher Award for the year 2022, and he's a Associate Editor for IJA. Over to you, sir.
Thank you, Chair, and with the permission from the Chair, it's very digit number in the post-lunch session. Thank you all for choosing Hall C. So, these are my disclosure. What exactly COPD is? You must have got some idea from my previous speaker. Pathologically, if you want to describe, it's a complex interaction of the gene, environment over lifetime, giving rise to a separate entity or the spectrum of disease that can be characterized under COPD. They are classically known as blue bloaters, that is the chronic bronchitis, and pink puffer, that is the emphysema. Exactly pathologically, if I want to describe, it's a state of chronic and progressive inflammation that gives rise to obstruction of the airway, either because of the narrowing of the bronchi or because of the collapse of the alveoli. Both gives rise to obstruction. They are progressive in nature and rarely reversible. Although it is classically described as a disease of the pulmonary system in the aged, it also affects the young and also has extrapulmonary manifestation, sometimes involving even your psychosocial health, giving rise to anxiety, depression, muscle wasting, and affect other important system like cardiovascular system. If you look into the clinical diagnosis of COPD, what exactly we understand is the patient should have certain chronic respiratory symptoms like dyspnea, cough, phlegm with or without exacerbation, plus a spirometric evaluation giving rise to FEV1 by FBC of less than 0.7. I'm not going into detail of this. Already my previous speaker has mentioned about this, and the gold criteria also was mentioned, how the magnitude of FEV1 or predicted FEV1 was described in form of mild, moderate, severe, and very severe. Preoperative optimization ideally should send the patient to a pulmonary rehabilitation clinic. It's usually spanned over a month of 2 months, where almost 16 to 20 sessions, each session of around 2 hours need to be taken, where one would be looking into not only the smoking cessation, drug therapy, treating the infection and respiratory physiotherapy, but also to look holistically to the patient's need in terms of nutrition, psychosocial health, breathing exercises, and educating the patients to cope up with the COPD even after the surgery. As a physician anesthesiologist, most of the times our role is limited to the 4 important aspects, that is smoking cessation, optimization of drug therapy, that is the bronchodilator therapy, treatment of the infection, and respiratory muscle exercise. The limited time what we get as a physician anesthesiologist before surgery, you can look upon or touch upon these 4 important aspects. So I will be covering these 4 aspects only for today's lecture. First is smoking cessation. Almost whatever program, either under pulmonary rehabilitation program or any short-term programs, smoking cessation is an integral part. Smoking affects all the systems, respiratory, cardiovascular, blood clottings, and metabolic pathway, and each of this pathway has an important anesthetic concern with it, like a hyperreactive airway, a pulmonary arterial hypertension in the immediate pre-op periods, platelet aggregation that may require antiplatelet medications in the preoperative periods, hepatic enzyme induction with smoking may also alter your pharmacokinetics of the drugs what we usually use during our anesthesia inductions. What exactly the right time to quit smoking? The experts say, the philosophers say, there is nothing called a wrong time to start a right thing. If you stop it for even for 20 minutes, you get the beneficial effect. However, you get the maximum benefit of quitting smoking so far anesthesia is concerned if you stop it before 8 weeks. What does the literature say for short-term abstinence? Many of the learned colleagues might have read some literature which said that if you stop smoking abruptly, probably your requirement of opioid analgesia increases because you are withdrawing the nicotine abruptly. Some may say that some literature is there that if you stop smoking just for a short period, then probably these patients are more prone for nausea and vomiting. However, most of this literature, whatever is available, they are of short studies and the results are not well founded. So short-term abstinence from the tobacco does not increase the risk of complication after surgery. This is the gist of most of the widely conducted multisystemic studies. So if there is no complication of stopping a bad thing like smoking, then why we should not stop smoking? In the first instance, we see the patients. That is the gist. So as a physician, anesthesiologist, or as a doctor, whenever we see a patient smoking, our duty is whether the patient is going for a surgery or going for a pulmonary rehabilitation, he should be asked to stop smoking then and there itself. Looking into the evidence, if you see that if you stop smoking immediately, one example I would like to give, there is a reduction in the carbon monoxide. This carbon monoxide is like a double attack. One is carbon monoxide shifts the oxygen dissociation curve to the left, therefore it reduces the oxygen delivered to the tissue. Second, because of carbon monoxide's affinity for the hemoglobin and having the same spectrum of infrared light, it will show you a higher value on the pulse oximeter. That means it will not allow you to give additional oxygen because you will be under false impression that the pulse oximeter saturation is high. So it is always prudent to stop the smoking whenever you see a patient smoking, whether the patient is posted for surgery immediately within 1 hour for emergency surgery or for elective surgery after 1 week. Next comes to the drug therapy. Drug therapy is classically taken from the GOLD 2023 criteria. Here, the division of the patients who requires different drugs has been made very simple. Like one group of patients who are either low or high on symptoms, but they have a high risk of exacerbation, they are coming under group E. The rest of the patients into divided into two groups. One groups who are low on symptom but also low on the risk of exacerbation. Another group is they are low on risk of exacerbation but high on risk of symptoms. The symptoms means the dyspnea scale using medical research council scale and a COPD assessment scale which basically looks into the patient's limitation of the lifestyle activity. If the score is less than 10, that means his COPD is not disturbing his day-to-day activity. If it is more than 10, it's disturbing his day-to-day activity. Similarly, if a dyspnea scale is more than 1, then definitely the patient is having problem most of the times. The drugs that are used in this GOLD 2023 criteria is short-acting and long-acting beta agonist, short-acting and long-acting muscarinic antagonist, and inhalational corticosteroids. So this is classically called SABA, LABA, SAMA and LAMA and ICS. How they have described these drugs, how to use drugs where? For acute treatment, only the short-acting beta agonists were prescribed. You can add along with the SAMA. Similarly, for patients who are in group A, that means they are low on symptom and low on risk of exacerbation. There also you can get along if you start a single drugs like a long-acting beta agonist or long-acting muscarinic antagonist. However, if the patient is high on symptoms, you get majority of the benefit if you give combination of the drugs LABA and LAMA. When to start inhalational corticosteroids? Here in 2023 guidelines, they have used use of or biomarkers like absolute eosinophil count as a marker to see the severity and guide you about the use of inhalational corticosteroids. If AEC value is more than 300, then definitely you should use inhalational corticosteroid even if patient is low on risk of exacerbation. Of course, all the patients who are high on risk of exacerbation and not getting stabilized with LABA and LAMA, it's very prudent that you should add the inhalational corticosteroid as early as possible. They are also very clear that you usually get more benefit when you give combination of the drugs, and at the same time they have also told that there is no role of starting the patient on inhalational corticosteroid with a single LABA or single LAMA. Always, if you want to start with inhalational corticosteroids, you should first start with the LABA plus LAMA, then only you can add on the inhalational corticosteroids. Even if you are not able to control the entire symptom of the patients or the exacerbation, then they have also suggested you can add a oral phosphodiesterase 4 inhibitor like roflumilast if the FEV1 is in the severe category, that is less than 50%, and the patient is not responding to this triple inhaler therapy. The role of systemic steroid is very much explicitly stated. They said that there is a role of systemic steroid like prednisolone only if there is a acute exacerbation. They have not found any difference between whether you give a oral steroid or systemic or parenteral steroid. However, they said that if you are choosing a long-acting inhalational steroid like budesonide, then you can escape many of the complications of steroid like hyperglycemia, hypertension, ulceration, and all those things. Few studies again there is a conflict. If you are starting on systemic steroid, we should give it for short term or for a long term. And it was found that majority of the clinicians, they favor a short term steroid, and they found no difference in relapse of exacerbation or symptom controls, whether you go for a short term and long term therapy. However, patients who are on long term therapy, they have more complications, what I have said, hypertension and hyperglycemia. The Goal 2023 criteria does not permit or does not suggest use of inhalational corticosteroid if the AEC count is less than 100. Rather, it says that you go with the roflumilast if the symptoms are not getting controlled with the double therapy. Second is, whenever there is a risk of pneumonia or the patient has history of repeated risk of pneumonia, then also they don't suggest giving the inhalational steroids. And of course, whenever there is a mycobacterial infections, that does not permit giving the inhalational steroids. Next is treatment of infection. The study says that the majority of the patients who have an exacerbation are also having an infection with a bacteria or virus. And majority of the clinicians, systemic trials has shown that more than 70% of the clinicians, they favored use of antibiotic for all the patients who has a high risk of AECOPD, and they found the beneficial effect in the terms of less hospital stay and the relapse rate. And it's always prudent to take a sputum culture and sensitivity before you start the antibiotics to pick up the right bug and the right antibiotic for the patients. Oxygen, nutrition and vaccination, their importance cannot be undermined whenever we are looking into the other aspects. All the patients who have a PO2 of less than 60, they probably need a oxygen supplementation, and the patients who have pulmonary arterial hypertension, probably they are also get benefited by a long oxygen supplementation in the preoperative period during the pulmonary rehabilitation program. A oxygenation of around 15 hours per day may be required, and the target is to have a oxygen saturation of 88 to 92%. Nutrition, all the patients who have less than 3.5, they should be provided additional nutrition, but because that keep them well motivated. And all the patients who are in the elderly age group, definitely chances should be taken to vaccinate them with flu, pneumococcal and the COVID vaccinations as soon as possible to avoid post-operative problems of pneumonia. Mind-body interventions in the current age, we all know that how the breathing exercise, yoga, relaxation, they help in keeping the patient motivated. And the studies also have proven that if the patients who are undergoing this type of relaxation technique, their post-operative complications are much less common compared to the other patients. Optimization of pulmonary arterial hypertension. This is one of the manifestations of COPD where the anesthesiologist is a little bit scared. Many times these patients, they pose many clinical dilemma whether to go with regional anesthesia or general anesthesia, whether to go for laparoscopy, whether not to go for open type of surgery. Here one thing I would like to say that patients who have pulmonary hypertension, they need to be optimized with a target control. That means it's not possible to put a PA catheter to all these patients to look at their PA pressures, but the bronchodilator therapy, the antibiotic therapy, and the breathing exercise to be administered in such a way that their exercise capacity increases, and that can be easily measured with a 6-minute walk test. See that if ABG is possible, they remain little bit alkaline so that the effects of hypoxia, hypercarbia, acidosis, all those things on the pulmonary arterial hypertension can be minimized. And if possible, with a transthoracic echo, you can see that the right arterial pressure is less than 7 millimeter of mercury. Or these patients again probably may require diuretics and anticoagulation therapy to get control over the hypercoagulable or hyperthrombotic state in this group of patients. Respiratory physiotherapy is one of the most important aspect in where the anesthesiologist or the hospital can help the patient in a short term. So both inspiratory and expiratory exercise can be given to the patients whatever time the patient can do, either in the home-based therapy or in the hospital-based therapy. So here, most of the times what we do is we give an incentive spirometer, but different commercial devices are also available where the patient can do a graded exercise for toning up its inspiratory muscles and the expiratory muscles. To summarize, respiratory physiotherapy along with cessation of the smoking, adjustment of the bronchodilators, keeping the patient well hydrated to remove the secretion, providing a good nutrition, education and motivating the patients to cope up with COPD do wonderful while dealing with these patients or preparing these patients for any type of surgery. This is what we have discussed in last 15 to 17 minutes. This just comes under the mnemonics COPD, where we look basically for the cessation of the smoking, judicious use of inhalational corticosteroids, role of oxygen and optimizing the symptom. What does that mean is the patient should be non-pyrexic, the patient should produce clear sputum less than 100 ml per day, patient should not have any raised total leukocyte count, no foul smelling sputum and much reduced respiratory discomfort. PFT need to be optimized with respiratory exercises. Pulmonary rehabilitation, if possible, to be continued with vaccination strategy. Bronchodilators and antibiotic has to be used as appropriate to get control over the symptom. Thank you for patient listening. And I thank the organizing team and the scientific committee members for giving me the opportunity. Thank you all.
Thank you, sir.